Begin to talk about the onset and diagnosis of oppositional defiant disorder and conduct disorder. As the text states, social workers should always engage in a multifaceted approach to oppositional defiant disorder and conduct disorder, using many informants, the child, parents, school personnel, etc., to obtain reports and different methods such as interviewing, rating scales, and observations of the child to formulate their assessments, as the DSM criteria require behavior problems in more than one setting. Professionals should also consider whether the behaviors can be attributed to any of the following: ADHD, recent stressful life events, so discount it as a adjustment disorder, behaviors that act as a protection for the child, or symptomatic outbursts due to PTSD, or a mood disturbance disorder or psychosis. Though the text makes little mention of adults with such behavior disorders, it is because these individuals with oppositional defiant disorder or conduct disorder are not functional within normative society as adults. The adults with these disorders, disruptive behavior disorders, find it hard to maintain a job because they continually defy authority and become easily agitated and sometimes result to physical violence. And they just really don't function as a contributing member of society. Oftentimes, adults with such behaviors, if they have not gotten treatment in childhood, find themselves out of a job, unable to maintain a healthy relationship with anyone really, or in the worst case scenario, they end up in prison because they keep committing significant crimes and getting in trouble with the law. Adults with oppositional defiant disorder or conduct disorder are often diagnosed with antisocial personality disorder because as adults, the behaviors characteristic of oppositional defiant disorder and conduct disorder become increasingly problematic. And as I said before, a lot of these adults who have these disorders and have not gotten treatment for them find themselves in prison because they have broken the law. Alright, so I'm going to preface this slide by saying disruptive behavior disorders can be very difficult to diagnose. Children with anxiety, depression, chronic stress, and other conditions may act out in ways that seem like a disruptive behavior disorder. In addition, oppositional defiant disorder and conduct disorder are often comorbid with other anxiety and mood-related disorders, as I talked about in the last slide. Currently, there are no biological markers for oppositional defiant disorder and conduct disorder, so a comprehensive diagnostic evaluation is needed to diagnose a child showing behaviors congruent with these disorders. As for how these disorders are treated, the book states 4 main interventions that can be used for children with oppositional defiant disorder. They are as follows: social information processing, which is made up of encoding and interpreting situational and internal cues, setting goals and determining possible responses, and role-playing. Parent training, in which parents are taught to specify goals for behavioral change, track behaviors, and use positive reinforcement. Multisystemic therapy, otherwise known as MST, which is a manualized, ecologically based family preservation program targeted at juvenile offending. Then finally, there is functional family therapy, which is a behavioral systems family therapy targeted at juvenile offending. So the reality of conduct disorder and oppositional defiant disorder is a pretty grim one. Unfortunately, youth displaying antisocial behaviors concurrent with conduct disorder and oppositional defiant disorder frequently come from families in which parents are unable to give love, set consistent limits, and provide the controls that allow children to develop the necessary personal tools to cope with the world in which they live. Under these circumstances, treatment is not always a luxury these children are able to be awarded. This exponentially increases the risk of delinquency in children with conduct disorder and oppositional defiant disorder, which we will talk about next. We're going to move into discussion of conduct disorder, oppositional defiant disorder, and their effect on delinquency. Delinquency is defined as the acts committed by a minor which are prohibited by criminal law. These can include theft, burglary, robbery, violence, vandalism, drug use, arson, breaking curfew, and running away. The last two are specific to adolescents, so think of things that only minors can break, such as underage drinking, breaking curfew, and running away. So as you can imagine, a child or an adolescent with conduct disorder or oppositional defiant disorder might get into a little bit more trouble than the usual child. The higher number of risk factors that a child has, such as low socioeconomic status, poor community ties, family problems, parental drug abuse, the more likely he or she is to become a persistent delinquent. And in the criminal justice system, a persistent delinquent or a persistent life course delinquent is defined as someone who continually commits crimes up into adulthood. So children who go untreated for their conduct disorder or oppositional defiant disorder are more likely to become these persistent delinquents, just because of the factors that affect them. They can't really, if they don't get treatment, then they can't really control their behavior. In addition, adolescents who experience more intense moods, mood swings, anxiety, and restlessness, and impulsivity than other adolescents have the highest crime rates. So these mood and behavioral changes that are associated with like family conflict and all of those other risk factors, they're associated with conduct disorder, oppositional defiant disorder, and later on, antisocial behavior. So these facts kind of paint a very grim picture for children and adolescents with conduct disorder and oppositional defiant disorder. Psychologically troubled youth often do poorly in school, and school failure leads to delinquency. Unfortunately, one of the characteristics of conduct disorder and oppositional defiant disorder is having a low IQ or learning delays. So we're already seeing that with those children. Psychologically troubled youth have conflict-ridden social relationships that make them prone to commit delinquent acts. So when you think of a child with oppositional defiant disorder or conduct disorder, they're either deliberately ignoring their peers or become physically violent with their peers. So already they are not taking the steps to have good relationships. While good parenting is considered a barrier against delinquency, youth who maintain abnormal psychological characteristics such as low self-esteem, a hostile view of relationships, and acceptance of deviant behavioral norms may neutralize the influence of positive parenting on controlling their conduct. So while parents can try to control the behaviors of their child with oppositional defiant disorder or conduct disorder, this is really just saying that treatment is the best course for dealing with these children. Also, kids who are delinquent have reduced life chances, and they do poorly in school as adults, and as adults are relegated to lower class economic status. So additionally, conduct disorder and impulse control systems early in childhood present an increased risk of persistent delinquency into adulthood, especially in boys. So we talked about some of those risk factors for conduct disorder and oppositional defiant disorder earlier in this presentation. And as I said before, like many disorders that we've talked about, an early onset is really indicative of poor outcomes for these children. So the earlier we can get treatment for these kids, the better.